So I gave myself 27 minutes, or 20 minutes, to give you a sort of a Chiari 101. Let's see how I do. Okay. So first off, when we talk about Chiari malformations, the original description, there are actually 4 types. You can, for simplicity's sake, we can just ignore type 3 and type 4. We're essentially talking about the type 1s. The type 2s are by and large found in patients with spina bifida. So I bring up Chiari 2s because there's a lot of controversy regarding the language used, and some people get upset when you talk about curing Chiari 1s, but you could actually, to some degree, cure Chiari 2 with fetal surgery. If you repair the spina bifida, the hindbrain malformation, the Chiari can actually get better. And this is a gratuitous plug, of course, but one of the authors of this study, Tim Krummelholm, is our fetal surgeon here, and we actually do these surgeries at Medical City. Okay, so moving past the gratuitous plug, Chiari malformations are actually more common than people actually think. Generally, they're not genetically related. They're mostly sporadic. And basically the best way to think of them, and of course we do try and quantitate things, but qualitatively the best way to think is that the back part of the brain cavity is too small, so the lower part of the cerebellum or the tonsils ends up pushing out into the spinal canal. And symptoms can develop in childhood, but many times patients make it to adulthood before they start having symptoms. Chiari was thought to be exceedingly rare until we started imaging patients with MRIs in sort of the late 80s, early 90s. And this paper at the end of the 90s really encapsulated our new understanding of how common this condition is, and really all the symptoms that can be associated with them. The list is quite long, but the most common complaints that we hear are suboccipital or headaches in the back of the head, neck pain and weakness and numbness tends to also occur quite commonly. And the most common presenting sign that we pick up on a physical exam are increased reflexes in the lower extremities, but there are lots of other things on exam that Chiaris can cause. When we talk about intervening surgically, the symptoms that seem to respond to best to the headaches are headaches that are worsened with coughing, sneezing, or straining, and any symptom that really can be associated with compression of the brain. When you do the decompression, we tend to have good results with doing that kind of surgery. So we get MRIs by and large now to see these things. Are very, very difficult to pick up on CAT scans. And basically, when we talk about how many millimeters is a Chiari, what we're speaking of is when you draw a line along the base of the skull, how much this part here is poking through into the spinal canal. So we would measure here up to sort of that line. And the MRIs can show other things. It shows how much compression of the brainstem or the spinal cord that you can get in this area. And also, if we look a little bit further up at the brain, we can pick up hydrocephalus or increased fluid pressure there, and Syringomyelia, which is increased fluid within the spinal cord itself. Further complicating the issue of how many millimeters is a Chiari is that the tonsils normally ascend with age. So in the pediatric population, that measurement is sort of a moving target. And in adults, you usually don't see the tonsils coming through the foramen magnum. The other thing about Chiari malformation is it's different than just how much of this cerebellum is poking through, because, this is a coned inversion of this patient, and this is not just the Chiari poking through. There's actually a brain tumor up here, which is putting pressure down, which is causing the tonsils to poke through because they're squeezing out to relieve the pressure. So, that's also a teaching point, that it's very important when you get a diagnosis of a Chiari malformation that you rule out, other causes, and it's important to get a brain MRI. Of course, if we have 1s, 2s, 3s, 4s, and it gets even more complicated, that there's people who refer to a 1.5 or complex Chiari, where it's not just the tonsils that are poking through, but you actually have parts of the brainstem that are going through as well. And making things even more complicated, there's a description of a Chiari I, where you actually don't have tonsillar herniation for whatever reason, but you do have that tightness in the posterior fossa. This was originally described and associated with Syringomyelia, but even in that paper that I pointed out from before, which had hundreds of patients, about 5% of them had true Chiari-like symptoms, but did not have any tonsillar herniation. So moving for a moment on Syringomyelia, which is a talk unto itself, but it's really hard to mention Chiari without Syringomyelia. So what we're talking about there is a fluid-filled sac within the spinal cord. So the gray here is our spinal cord, and this white is spinal fluid, which isn't supposed to be there. There's various other names by which it's called, hydrocephalus and spinal cord cyst, but it's essentially the same thing. And this generally causes symptoms with respect to the tracts that are going up and down from the brain to the spinal cord that control movement and sensation. If the Syringomyelia ends up getting into the brainstem, you can actually get brainstem symptoms. There's certain cases where scoliosis can be a presenting sign, and it can also cause chronic pain. Now, there's a lot of stuff out there with Ehlers-Danlos, so I thought I'd take a little bit of time to discuss it, but not a terrible amount. So it's a heritable disease of the connective tissue, which causes abnormality in a collagen, which is the protein structure of our connective tissue. Fairly common as well. So there does seem to be a cross-fertilization of these patients with Chiari. So a lot of times when patients have Chiaris, there's this question, do they have this as well? Because the collagen fibers, the protein is sort of abnormal, and that protein is in all of our connective tissue, it leads to problems of, in the joint, you have joint laxity because the ligaments and the tendons are loose. The skin is also more stretchy, which results in bruisability, and actually your internal organs have this as well. So in severe cases, you can actually have blood vessel fragility and internal organ fragility. Everybody always talks about genetic testing for that, which is good because some of the more severe forms of this do have genetic tests for it, but unfortunately the most common type, which is this hypermobility type, does not have a genetic marker. So a lot of times you really just make the diagnosis clinically, which is, and there's actually an objective scale called the Beighton scale, which we use to assess patients, but it doesn't assess all the joints. I don't make these diagnoses. I let geneticists and rheumatologists do it. Because what also complicates that is children, by and large, are looser than adults, and females are also more flexible than males. And anything that affects the joints themselves, either injury to it, increased muscle tone, or pain, can alter these scales. But in terms of the Chiari surgery, when a patient does require surgery, our goals are pretty straightforward. What we're trying to do is restore the normal anatomy. So the back part of the skull is too small to fit all the brain contents. So what we're trying to do is enlarge it. And at the same time, if symptoms are caused by a combination of abnormal CSF flow across the base of the skull and compression of, the brainstem and spinal cord and cerebellum. So we're trying to restore the normal flow of CSF and remove all the compression on the neural elements. Indications for decompression are as straightforward as this slide is. Symptoms. And that really is, the crux of all of this, is determining what symptom, and you saw that there's a laundry list of symptoms that could be caused by Chiari, but sometimes those same symptoms may occur, not associated with Chiari. So it really comes down to the surgeon or the practitioner to really tease out, are those symptoms truly related to the Chiari? By and large, if there's a Chiari with a dilated syrinx, that's an indication for decompression. And certain types of scoliosis, particularly the progressive curves when the spine is progressively getting more curved, there does appear to be in the literature some role for considering a decompression to try and prevent that from getting any worse. The size is not very well worked out in the literature, but essentially should be big enough so that you have a large enough hole here so that the tonsils are decompressed. 3 by 3 centimeters usually is good enough. What you want to do is avoid doing something too large, because if you do that, then you lose the ability of the bone holding the cerebellum in place, and actually you can get symptoms from the cerebellum actually falling out, which is called cerebellar slump. The other thing to be concerned about is this red hose here on either side of the vertebral arteries, and if you're not careful and you make that too large, you risk injuring the vertebral artery. Now, there are many different ways to do this. You can just take the bone off, which includes the back part of the occiput and the back part of the first cervical vertebra. Then the coverings or the dura of the brain, there are 2 layers, so you can open both of them. You can open one of them, and then the internal one tends to stretch a little bit more. After the dura is open, there is another layer of coverings all over the brain called the arachnoid. You can open that, leave that intact. There's also various different string-like adhesions from the arachnoid, which you can cut. The tonsils here, some people will shrink them sometimes, some people resect them. The only thing these are all different options that it's, really is, determined best by what the surgeon's experience is. The only thing that we do know is plugging the obex, which is the area underneath the tonsils here where their spinal fluid comes out of the spinal cord. We do know that's bad. So nobody does that anymore. And then after you've opened everything up with respect to the dura, then the next decision tree is, what do you do about the closure? You can, leave this hole completely open. You can take a piece of graft tissue off the shelf and you can just onlay it or just lay it down in there and close the muscle over that. You can suture it into place. You can use drains, or you can use various dural sealants to try and prevent leaks. You can consider doing some sort of reconstruction or putting a plate over there. So which is the best surgery? I refer to the PCORI as the Park-Reeves study, so I'd be interested to see how those results turn out. But the only thing that we know from the literature is this paper written by a good friend of mine, Susan Durham, who looked at all the literature that was out there, and this is a couple of years old already. And tried to figure out which was the best thing to do. The only thing that she can come up with was when you do the decompression without opening the dura, there's a higher risk of needing to do another operation, which would include opening the dura. If you start out opening the dura, there's a higher chance of having problems with CSF leakage. Time is a little short. I'll just mention very quickly about tethered cords, which is associated with Chiari malformations, and it's important to look for that before getting a lumbar MRI before going ahead with a Chiari decompression. And without obvious there is some controversy whether you can actually have a tethered cord without MRI evidence of the spinal cord being tethered. And I'll just leave it at that for now. Now, you can have increased pressures, spinal fluid pressures. You can have low spinal fluid pressures, which complicate things a bit because both can actually lead to tonsillar herniation or Chiari malformation. If there's increased pressure with hydrocephalus, it may be a better idea to, rather than do the decompression first, to start off with placing a shunt. And if there's low pressures, you need to look for a leak. As I mentioned before, with Ehlers-Danlos patients in particular, they're prone to have, because the dura, the coverings around the brain, they can be kind of super elastic and stretchy. They can develop leaks. If you have a leak, the primary treatment is just like, we see this quite often with pregnant women who've had like an epidural and they get like a wet tap. Start with caffeine hydration. If that doesn't work, you put like a blood patch at that area, and if that doesn't work, you can actually go looking to do directed things, which might include surgery. Complications from this surgery, by and large, are problems with leakage. A pseudomeningocele is when you get leakage that's contained under the skin. A CSF leak is exactly that. You get this clear fluid leaking from out of the skin. These are things that need to be addressed. Sometimes patients, even if they didn't have hydrocephalus before the surgery, they can get it afterwards. You can go get an inflammatory meningitis, which we treat with steroids. And because you're doing surgery, there's always the risk of infection. And of course, you can get recurrent. The symptoms can come back even after they've gone away. When that happens, we then take a look at, was the decompression good enough? Are there things that could be done better that might help reduce the symptoms? We look at the stability of the spine, and maybe now that we've done that surgery, there's instability there, and maybe the symptoms are coming from that, and we might need to consider a fusion operation. And then, of course, there's non-surgical treatment if we find that the surgery was adequate. The only thing I'll say about this is opioids are a bad choice for managing pain and headaches post-operatively. We want to limit the pain. We can't make it go away necessarily. And most of the time there's no one single bullet that makes things better. And a person's emotional state really affects this, because it's been clearly shown that it can become like this vicious cycle. You have anxiety, depression, self-esteem issues, and negative thinking and hopelessness. So, what's important is sort of manage expectations. You need to know that having no pain, no complications, a setback, and being able to be normal, that's a really high bar and might be difficult to accomplish. As you're going through the process, what might be better is to have an expectation of having less, not no pain, and there might be some complications or setbacks, and even if we can't get to normal, maybe getting better will be good enough. And there's a very complex interplay between how people perceive pain, their emotional state, and how they perceive pain, which is very important to manage. In working with a healthcare provider, what's important is that the provider, validates that the symptoms are real. It's never good to be dismissive with a patient and say this is all in your head. Because even if it's in the head, the pain, the discomfort, the suffering is real. And the patient in turn has to understand that there's going to be issues other than biologic that are to contribute to the pain, and those need to be addressed too. We need to, depression, anxiety that occurs either before having surgery or after, there's ways to address that. And, there's lots of other treatment modalities besides surgery, medication. There's behavioral therapy, relaxation, hypnosis, and these help. Taking a multifactorial approach to it really is beneficial. So we know a lot about Chiari. Clearly there's a lot more that needs to be learned. And there's lots of things that we can do to increase quality of life for patients with Chiaris. And, the real take-home ought to be that, the least that we can do invasively that'll result in symptomatic improvement is really the way we should choose to go. And that's all that I have.